Welcome back to the Ninja Nerd video podcast. Today we're going to be talking about acid-base disorders. Zach, how pumped are you?
I am so excited. It's going to be amazing.
It's going to be a lot of fun. We're going to have a few cases, well, 5 to be exact.
Yeah.
It's going to be what, Zach? Metabolic acidosis, but AGMA, NAGMA.
Yep, exactly.
Metabolic alkalosis.
Yep.
Respiratory acidosis and respiratory alkalosis.
That's you hit it nail on the head, buddy.
It'll be a little bit of a longer one.
I think it's going to be long, but we're going to make it fun. We're going to make it enjoyable. And I think that at the end of it, you guys will know acid-base disorders hands down.
100%. We're going to just rock their world.
Exactly.
So let's get right on into it then. We're going to start with case 1. Case 1 being anion gap metabolic acidosis, or really AGMA. So we have here a 45-year-old female presents to the emergency department with severe abdominal pain, rapid breathing, and confusion. A little bit more about the history. The patient reports that over the past several days, she has experienced a noticeable increase in polyuria, polydipsia, combined with nausea and intermittent vomiting. She has also experienced worsening fatigue and dizziness, which has escalated over the last 12 hours. Her intake has been significantly reduced to nausea, leading to decreased fluid consumption amidst her increased urinary output. Past medical history, she has type 2 diabetes managed with oral hypoglycemics and hypertension. Her medication list, she is only on 2 medications being metformin and lisinopril. Her review of systems, going down, we have respiratory, rapid breathing, no cough or wheeze. Cardio, she reports palpitations. And GI, she has severe abdominal pain, nausea, vomiting, unable to keep fluids down. What do you think so far, Zach?
I mean, this is definitely looking, her diabetes is making me think about a lot of stuff. The fact that has some fast breathing, she's peeing a lot, she's thirsty, she's not eating a lot. Something's definitely going on respectively with her diabetes. So I think I already have an idea, but I'll wait for some more information.
So vitals, blood pressure is 100/65. Heart rate is 120. She's tachy. Respiratory rate is 32 per minute. That's tachypnea.
Yeah.
Her temp is 37.6 Celsius or 99.7 Fahrenheit. And her oxygen saturation is 94% room air. Upon her physical exam, her general exam, she appears acutely ill and dehydrated. Her neuro exam, confused, disoriented to time and place. Respiratory, deep labored breathing. We note that this is a Kussmaul respiration.
Gotcha.
Cardiovascular, like we talked about just before, tachycardic with a regular rhythm, no murmurs. Abdominal is diffusely tender on palpation, no rebound, there's no guarding. Skin, dry mucous membranes, and decreased skin turgor. So again, kind of more so talking about that dehydration.
Yeah, definitely like hypovolemic in nature.
Okay, so getting into some pertinent lab testing here, starting off first with serum sodium, 138, potassium is 4.5, creatinine is 1.5, BUN is 30, glucose is 450.
Ooh, mama.
Bicarb is 12, anion gap of 30. Not too good so far.
No.
Not too good.
This is not compatible with life.
We'll make her right though.
We're gonna fix her up, I hope.
ABG. So when we got our ABG, we have a pH of 7.1, PCO2 of 18, and a PO2 92 millimeters of mercury.
Okay.
Her lactate is 5. Ketone bodies significantly elevated. And then we have a calculated serum osmolality, 330, osmolar gap of 10.
Okay.
Tons and tons of things to be thinking about here.
Yeah, there's a lot. Definitely a lot of things. It's pretty clear, I think, of what's going on with her, but we'll talk about is there anything else, like any other imaging or anything else that pops
so
up?
we do have imaging. We have a couple different images here. We have an abdominal x-ray, normal gas pattern, no evidence of obstruction or free air.
Okay.
And then a chest x-ray is a clear lung fields, normal cardiac silhouette.
All right.
So really just within normal limits.
All right.
So Zach, based upon all these clinical findings, we have vitals, we have lab testing, imaging, everything that we've gotten so far, how would you approach an anion gap metabolic acidosis?
Yeah, so I think you kind of set it up perfect for me is that, if I got an ABG and I see this patient's ABG, pH 7.1, she's definitely acidotic. I would look at her CO2. It's definitely low, and it's probably because she's breathing super fast, so she's super tachypnic, as you pointed out. The PO2 is 92. Her bicarb is what kind of concerns me, that it's 12. So being that her bicarb's 12, her pH is low. She has a metabolic acidosis. Her anion gap's greater than 12, so it's an AGMA. So right away, what I want you guys to remember when you think about AGMAs is to think about the mnemonic CULT. It's a terrible mnemonic, but it works in the sense of keeping things very simple for you. So K for ketoacidosis, U for uremic acidosis, L for lactic acidosis, and T for your toxic ingestions. And the reason why I like that is right off the get-go, I can kind of assume, look at their history, look at potential aspects of their physical exam, but then I can order the appropriate labs, or if I need to, imaging to go off of this. So let's say that we kind of go down this pathway for this patient. She has a lot of features that for me suggest DKA, diabetic ketoacidosis. She's a diabetic. She's maybe taking her oral anti-hypoglycemia or oral medications or anti-diabetic medications potentially. Not sure how consistent or compliant she is with it, but she's definitely, there's got to be some concern there.
She almost can't be.
I have some concern.
You have to think that there's some non-compliance going on here.
Exactly. So
you can't get to that point without.
No, to have a sugar of 450, I don't know. She's either just not sticking with it or she's just going ham and eating cupcakes all the time or something like that. But there's definitely concern there for maybe some non-compliance. Her sugar is pretty high. She's got elevated ketone bodies. And then again, she's got an acidosis. If I have diabetes, high glucose, and an acidosis with ketones, I'm thinking DKA. The other thing though that's weird with this one is we already know that she has DKA, but here's something else that she has. She has likely a lactic acidosis too. And I think the lactic acidosis is a byproduct of her DKA. So I think what happened is she has diabetes. She probably was non-compliant, maybe eating lots of sugary foods or whatever it might be, went into DKA, started having abdominal pain, vomiting, nausea, peeing a lot. And because of that, she probably lost a lot of fluids, became hypovolemic, and then developed lactic acidosis. So for this patient, her lactate tells me that it's elevated, and she probably has a combination of lactic acidosis, and on top of that, she has diabetic ketoacidosis. If I look for other things here, I could also consider, is there any evidence of uremic acidosis? I'd want to look at the kidney function, and the serum creatinine is 1.5, the BUN's 30. It's a little bit elevated, but it's not that significantly elevated to where I would actually be concerned that the uremia was contributing to this at all. I would really be looking for a very high BUN, and I'd be looking for a very elevated creatinine for me to be even considering uremic acidosis.
And then you wouldn't be thinking at all toxic alcohol ingestion, right? Because that osmolar gap is not quite where you would need it
Exactly.
to be.
Yeah, you're on the money there. Usually I like it greater than 10 to even start considering that.
She was right at 10.
Yeah, and so greater than 10, and then also history would usually kind of like lend to itself some concern here. And I don't see any worries for a toxic alcohol ingestion of any sort. So for me, right off the get-go, I think, metabolic acidosis, AGMA, ketones are elevated, and she has diabetes, DKA, lactate's elevated. Usually if your lactate's greater than 2, we can consider it somewhat of a lactic acidosis. I don't think her renal function suggests uremic acidosis, and she doesn't have an osmolar gap that's greater than 10, and I don't see anything in her history to suggest that. So that's how I would approach this patient's AGMA.
Okay. All right, so I'm just trying to think about this patient overall. What would you say, Zach, is the most concerning of her acidosis, and what complications is she most at risk for?
So for me, I worry about her breathing. So the fact that she's like breathing, I forget what it was, 32. 32. That's kind of concerning.
She's tachycardic.
Tachypnic. Exactly. So I think the tachycardia, the tachypnea, and even she's borderline. Her blood pressure is a little bit soft, but she's not technically hypotensive. And then the confusion, the disorientation, that kind of that concerns me. So I think there's a couple different things that I worry about for her, but I would say the biggest thing is definitely the respiratory compensation. So whenever you're acidotic, naturally what it does is it triggers your chemoreceptors, tells them, hey, I'm acidotic. Can you tell the actual lungs to breathe at a deeper rate, a deeper and breathe faster to blow off CO2? And her ABG suggests that because her CO2 is catastrophically low. Electrolyte imbalances is something I get super concerned with acidosis though, Rob, especially if they get really acidotic. It changes the movement of protons and potassium in and out of the cell. So what happens is if you're more acidotic, protons move into the cell and potassium moves out, and you can develop hyperkalemia, which can increase the risk of arrhythmias. So I don't see that on her BMP yet, but I'd be watching out for that. The scariest thing that I noticed in an ICU setting though, is refractory hypotension and arrhythmias. One thing about really, really bad acidosis is it can really wreak a lot of havoc on the heart and the blood vessels. So when the pH gets really, really low, your heart stops contracting very well, so contractility drops, and then your blood vessels dilate. And so it can actually make a patient a little bit more hypotensive. Something I noticed working in the ICU is that vasopressors stop working as well. So norepinephrine, epinephrine, all those things that we're supposed to put people on to push their blood pressure up, they stop working as well. So those are some things that I would really be careful of, and I would especially watch the potassium and watch closely on her ECG to make sure she doesn't get any kind of like weird like peak T waves or prolonged PR interval or widening of the QRS sine wave, all of those things. So that's something that I would be watching out for. But for her, it's really the respiratory compensation that I'm concerned about, as well as the volume depletion as the result of her DKA. So her hypovolemia is also concerning to me.
So there's a lot of things we're watching out for, especially that hyperkalemia, ECG changes, things that could really cause the patient some pretty bad things to happen.
Yeah, exactly. Yeah.
I mean, we're talking about possibly death.
Yep.
So a lot of things are concerning, but what do we do now at this point? We figured out what's going on. We have a really good history. All of our tests are in. We're following this patient closely.
Yeah.
What do we do now to treat this patient?
Yeah. So for this patient, it's all about, that's one of the nice things about acid-base disorders. It's all about treating the underlying cause. Yeah. So you have to just figure out what the underlying cause is. And once you diagnose that, you treat that. For her, it's DKA. So the frontline treatment for DKA is insulin. So for her, what I would do is I would start by giving her insulin. Probably put her on like an insulin infusion. Insulin infusion is going to be more closely titrated. And then what I would do is I would closely monitor her anion gap. And so, for example, if I put her on insulin and I give her fluids to replete the volume that she's lost, the fluid will help with improving her volume status. It'll help to improve her blood pressure, improve some of her tachycardia. And then when I give her insulin, the insulin will help to shuttle glucose into the cells and stop producing ketone bodies. And so what I'll notice is I monitor her anion gap, it'll start getting smaller and smaller and smaller and smaller to the point where it closes. And in other words, it gets less than 12. And once that happens, I can shut the insulin off. I've done everything I need to do. So that's the first thing I would do for this patient. Get her on insulin, give her some fluids, closely monitor her potassium and her other electrolytes, and then watch her anion gap to see when it closes. A lot of the times people will see, oh, it's a metabolic acidosis, pH is 7.1. Give them bicarbonate. Not necessarily. Unless vasopressors aren't working, and if a patient's on multiple vasopressors, sure, you can give them sodium bicarbonate, but it's never the answer for a diabetic ketoacidosis, and it's really never the answer for a lactic acidosis. Unless the pH is less than like 7.15, it's just not worth it. Okay. And you have to treat the underlying cause. That would be the big thing for her. I would say like a lot of the times after you said, you treat the cause, you give them sodium bicarb only when it's less than 7.15. People say, oh, what about dialysis? The only indications that you would do for a dialysis is if a patient has refractory acidosis, that you treat the underlying cause, you've given them bicarbonate, and they're still not improving. For this patient, DKA, lactic acidosis, you give them insulin, you give them fluids, they'll improve, their anion gap will drop, their lactate will close, and they will start to steadily improve, and you won't have to give them any bicarbonate or do any kinds of like interventions for this patient.
So with this patient, treating the underlying cause, you really can't go wrong.
Yep.
And most likely you're going to fix it right away.
Exactly. Yep. That's the key. Okay. That's the key.
Well, there's case one.
We nailed it.
Not too bad.
I don't think that was too bad, right?
No, not too bad.
All right.
Let's keep moving through. We've got the next case. Case two is still part of a metabolic acidosis, but this one is a normal anion gap metabolic acidosis, anagma.
All right.
So we have a 62-year-old male presented to the emergency department with progressive weakness and difficulty breathing. His history: the patient reports feeling increasingly weak over the past few days, accompanied by significant muscle cramps, shortness of breath on exertion. He also mentions a recent increase in the frequency of urination and thirst, which he initially attributed to the hot weather. The patient admits to consuming large amounts of antacids due to chronic heartburn. His past medical history is a chronic kidney disease. He's in stage 3, GERD, and hypertension. Medications are calcium carbonate, which is his antacid, lisinopril, and amlodipine. Review of systems: we have respiratory, increased work of breathing, no cough or wheeze. GI, frequent heartburn, managed with over-the-counter meds, the antacids. MSK is muscle weakness and cramps he's experiencing. Some vitals we have for this gentleman: blood pressure is 145/89, a little elevated. Heart rate is 88. Respiratory rate is 24, again, a little elevated. Temperature is 37.1 Celsius or 98.8 Fahrenheit. and his oxygen saturation is 96% on room air. Physical exam, general. We have an elderly male appearing fatigued overall. Respiratory, mild tachypnea, no audible wheezes or crackles. Cardio, regular rate and rhythm, no murmurs. And MSK, like we talked about, generalized muscle weakness and cramping.
Okay.
So overall, Zach, any thoughts so far for this gentleman?
I mean, nothing's really popping out right away. There is some, I think, again, concerns here. Something's really kind of off with the frequent urination and thirst. And I'm not sure that this is kind of trying to distract me, but the large amount of antacids due to chronic heartburn, I'm not sure what to make of that yet. But
Yeah.
but yeah, hit me with some more.
Let's keep going. So some laboratory testing we get back. We have in order here, serum sodium is 138, potassium is 4, serum chloride is 112, serum creatinine is 1.8, his BUN is 29, serum bicarbonate 16, calcium is 10.2, magnesium is 2.1. You get an ABG, you get the following of a pH of 7.28, PCO2 of 38, and a PO2 of 90. His serum anion gap is 10. It's within normal limits,
Okay.
hence the name.
Yeah.
And urine anion gap is 20.
Okay. All right.
So indicative of a decreased ability to excrete ammonium, suggesting a renal cause.
Yeah, this one's definitely, there's more kind of coming to me now with this once I got some of the labs.
So that was a big red flag right there.
Yeah. The urine anion
The urine
gap.
anion gap.
Yeah.
Okay.
Yep.
Imaging, we just get a chest x-ray and there's no issues at all with that.
Okay.
So Zach, let's go ahead and let's dissect this case. Let's go through it. We have all of the pertinent findings.
Yeah.
We have the history. A lot of things are popping out, some red flags. How would you go ahead and approach this patient with an AGMA?
Yeah, so a lot of this stuff is great, but I think one thing that I like to look at based upon a lot of the literature is the urine anion gap. So for example, if I looked at this patient's ABG, it suggests they have an acidosis, so the pH is 7.28. The bicarb 16, so that's low. So they have a metabolic acidosis, but their anion gap's 10. So it's a NAGMA, as Rob pointed out. So then for me, the next test that is suggested is to look at the urine anion gap. The reason why is it tells you, is the patient's NAGMA renally related or is it extrarenally related? And that helps me a lot. And that's what is important to me because nothing came up in the patient's history that suggested that this was extrarenal. And that's what was kind of weird for me. So when I look at here and I see the urine anion gap is positive, and that's what you want to remember is if it's positive, that tells me it's a renal cause. I remember there's a kind of from one of the books that if the urine anion gap is negative, so you can remember negative. So the gut tells you that it's probably from a GI source of sorts. So that's right away the big answer for me. Urine anion gap's positive, it's likely a renal cause. So then I got to think about this. Okay, if it's a renal cause, there's 3 potential differentials. 1 is chronic kidney disease. 2 is a renal tubular acidosis type 1. And 3 is a renal tubular acidosis type 4. These are not easy diagnoses to make. So what I like to do is I like to look at their GFR, kind of get an idea or some degree of their renal function. And then what I like to look at is I like to look at their potassium. And lastly, I like to look at their urine pH. Those 3 things can give me somewhat of an idea of what's going on with the patient. So for example, this patient here, I'm looking at what's going on. I see a positive urine anion gap. I see a potassium that's kind of like on the normal range though. And I see a creatinine that's kind of just a little bit elevated and a BUN that's a little bit elevated. So for this one right away, I'm kind of thinking, hey, this could be potentially CKD. I don't have a GFR that's listed, but for me, it could be CKD. The other thing is I would have to look at the if it's RTA1 or RTA4. RTA1 will usually have to have a low potassium. So usually the patient would have hypokalemia. I don't see any hypokalemia here. So that's one thing. And then I wasn't given a urine pH. So I don't think that this is leading me towards a direction because the urine pH, it would actually have to be for RTA1, it would have to be greater than 5.5. So they look for a higher urine pH. I don't think this is an RTA1, and I don't think it's an RTA4 because RTA4 usually has hyperkalemia.
So being that this patient has a past medical history of CKD type 3, can't we just pretty much assumed that.
Yeah. So that's you made a good point.
I don't want to ever assume something, but like it's pretty much right there in front of you.
That's the whole thing. So Rob made a perfect point here. It's almost impossible to make a diagnosis of RTA1 and RTA4, like he said, if a patient has abnormal renal function. And that's what Rob kind of hit the nail on the head there, that if the GFR is normal, you could consider that the patient could have an RTA1 or RTA4. You could entertain that idea. But if they have a diminished or reduced GFR or some abnormal renal function, you cannot definitively make a diagnosis of RTA1 and RTA4. So boom, nailed it. That's what makes me think that this is likely a degree of her underlying CKD that's making me think this. If the urine anion gap was negative, you can think negative, that would make me think about a GI source. Are they having like profuse diarrhea? Because when you have diarrhea, you lose a lot of bicarbonate. Nothing in her history suggests that she's having any type of diarrhea. And then if that's the case, I could even look at another one called RTA2. And RTA2, you would have to have first a negative anion gap, but you would have to have hypokalemia and you would have to have an acidic urine, a urine pH less than 5.5. Those things aren't listed here, but that's something that I would have to think about. So the perfect way you lined it up, I checked the urine anion gap. It's positive. From there, renal function, does she have diminished? Yes, it's CKD. You can't really go any further and say RTA1 or RTA4. And the fact that the urine anion gap is positive, it can't be diarrhea and it can't be RTA2.
And not to mention RTA, they're pretty freaking rare, right?
They're tough. They're tough to make a diagnosis on. They're not super common.
Yeah.
They're one of those that are great for your board exam, but in real life, you're not going to see them too often.
Awesome. All right, so let's keep moving on with this case then. We're almost done with this one. We have to now figure out, we figured out all the complications, everything we know so far. How do we treat this patient?
For this patient, honestly, bicarbonate. This is kind of the patient where you can probably put them on bicarbonate. Obviously, ideally, every disease, you have to treat the underlying disease. So improving her renal function if possible, but with CKD, the damage has already been done. So unfortunately, when patients have CKD, you can't really reverse what's already been done. You can just hopefully prevent recurrent injury. So if they have hypertension, treat that. If she has diabetes, treat those things. But for her, honestly, it would just be putting her on some sodium bicarbonate tablets, and that would be it. If her renal function started going up and up and up, and I couldn't get her to improve off the sodium bicarbonate, that's when I could consider something like dialysis. But oftentimes, this is a super straightforward one. Give her some sodium bicarbonate and treat her underlying disease. Normalize the pH, and you're good to go.
I think our patient suddenly became a female.
Oh, jeez. I'm so sorry. Yep.
No, that was honestly funny. Yeah. Let's move right into case 3, metabolic alkalosis. We have a 48-year-old female presents to the emergency department with complaints of persistent nausea, repeated episodes of vomiting, and generalized weakness. History: the patient reports that she has been experiencing nausea and vomiting for the past week, which she has initially attributed to a stomach bug. She also admits to using over-the-counter diuretics recently to help her lose some weight. Maybe I should try the same thing.
I should do this. I was going to say.
I think she's on to something there, buddy.
All that water weight's gone, but now she's in the hospital, so who knows? I don't know.
Maybe not a great idea. The vomiting has been severe, with up to 5 to 6 episodes per day, and she has been unable to keep down any food or fluids since yesterday. Past medical history: hypertension, and no previous episodes of similar symptoms like this ever before. Medications: she's on hydrochlorothiazide, self-administered. She was not prescribed that. Amlodipine for hypertension. Her review of systems: GI, like we talked about. She has severe nausea, vomiting, unable to tolerate anything oral. Cardio: no chest pain, no palpitations. Neuro: she does report dizziness, especially upon standing. Her vitals: we have blood pressure 100/60. That's a bit soft right there. Heart rate is 110. She's tachy. Respiratory rate is 18. Her temp is 36.8 Celsius. Oxygen saturation is 97% on room air. Going a little bit further, her physical exam: general, appears dehydrated and lethargic. Cardio: tachycardic, no normal rhythm, no murmurs. Abdominal is soft, non-distended, no rebound, no guarding, but she does have diffuse mild tenderness on palpation. Skin: dry mucous membranes, decreased skin turgor. As we talked about, she's overall dehydrated.
Yeah.
So we're going to go ahead and get some lab testing now. Same thing we've been getting for each patient so far. Sodium is at 140, potassium is at 3, chloride's 90, bicarb is 36, that's elevated. Serum creatinine is 1.1, BUN is 25, Urine chloride is 15.
Okay.
What is that, Zach? Low?
I've never ordered one, but usually it indicates that it's low. It's usually kind of like we call it a saline or volume responsive.
So it's just not a normal test to get.
Yeah, I've never really ordered it, but it is something off the board exams that if you check the urine chloride, it tells you if they're going to respond to normal saline or if they're not going to respond to normal saline.
All right. And then the last thing we do is we order an ABG, which is a pH of 7.52, PCO2 of 44, and the O2 of 98.
Okay.
So we have everything we need now to kind of pour through this patient's history, exam, everything, and let's talk complications. What is she going through?
Yeah, so with her, definitely, as you said, from the ABG, 7.5, it's elevated. Her bicarb is elevated, so both of them are going up, metabolic alkalosis. I think right off the get-go, I look at her situation and her history kind of told me everything. That's why I don't think a urine chloride is always super helpful. But the fact that she's kind of like a little bit tachycardic, she has a softish kind of blood pressure. She has physical exam findings that she appears dehydrated, like the decreased skin turgor and the dry mucous membranes. And those kinds of findings that makes me think that she's probably kind of like what's called a hypovolemic metabolic alkalosis. And the reason why that's important is because right off the get-go, then I kind of think, okay, where is she losing the volume from? Where's this chloride-rich fluid coming from? And from her, it's likely coming from her GIT, not from her kidneys. And so it's not diuretics related. There's a rare disease called Barter and Gittleman syndrome. We see it in kids. It's unlikely that. So then it kind of just comes down to it's likely GI related. And in her, it's likely vomiting. Or if she had like a bowel obstruction, she had an NG tube in and they were suctioning out tons of hydrochloric acid, that could be another way. But for her, it's likely all vomiting. That's where when you brought up the exam or the urine chloride, sometimes we can look at the urine chloride, and if the urine chloride is kind of low, it indicates that they would respond to normal saline. And these are patients who usually are going to be more particularly on the hypovolemic side. So those extrarenal ones like vomiting, or if they potentially had a recent, like a prior diuretic use, that could be patients who are going to be a little bit more volume responsive. So for her, her. Last patient was a him and I called him a her. So for her, this one, again, it's really important to remember. History suggests that it's likely vomiting. Her exam suggests that she's hypovolemic. So from there, I'm going to put her into the camp of saying that her likely cause of metabolic alkalosis is the profuse vomiting like an exorcist. And that's what I would say her cause is. If there was an example, let's say she came in, she had a elevated bicarb, an elevated pH, her blood pressure's up. She has also features of hypervolemia, maybe some edema, maybe it's like pulmonary edema, peripheral edema, ascites, things like that, things that are making me think that she's more on the hypervolemic side. That's when I would think about a disease like hyperaldosteronism. So that's when I would check the renin levels and aldosterone levels. But for her, she doesn't have any of those features. I think it's a dead giveaway. Plus, patients with hyperaldosteronism, they oftentimes have like their potassium definitely does tank and their sodium oftentimes will go up. And so she would have hypernatremia and she would also have hypokalemia. So for this one, I don't think that's likely the case. Hers definitely suggests it's a hypovolemic, and I would think her cause is likely from vomiting.
Is that your way of delineating basically if it's a GI or a renal cause?
So for a GI renal cause, you can do it just off history. Like if a patient says, hey, I've been on diuretics and I've been using them pretty consistently, that would likely be the cause. And for this patient, was she using, she was using diuretics, wasn't she?
Yeah.
So for her, she actually has a double whammy now that I'm looking at it.
It's almost, she's losing a lot.
Exactly, yeah. So for her, she actually has two reasons as to why she would have a metabolic alkalosis. It's because of the prior diuretic use, and on top of that, the excessive vomiting. So her history would definitely tell me that. And that's what's going to be more important. But if you look at the urine chloride is actually pretty low. And that suggests that she had some prior diuretics that she was using, or she's been excessively vomiting or having things suctioned from her stomach via an NG tube. So I think there's two ways that you can look at it. If the urine chloride's low, it's likely prior diuretics, vomiting, NG tube suction. If it was elevated, it could be hyperaldosteronism, or it could be, are they actively using diuretics that is pumping chloride on the urine at that moment? And so for this scenario, her history gives it away. And I think this is definitely a combination of diuretics from the hydrochlorothiazide as well as the profuse vomiting.
Okay. Biggest complications, what are you most concerned about?
Hypokalemia, I would say, would be the big one. So electrolyte imbalances is pretty common with acid-base disorders, but potassium is the most sensitive. So in patients who have metabolic alkalosis, less protons are being shunted into the cell and less potassium ions are coming out of the cell into the blood. So hypokalemia can start to occur. So I'd watch those T waves, make sure that they're not inverting or flattening. Make sure you're watching out for U waves. Those are some big things. Respiratory compensation wise, I wouldn't say it's a super common one, but they could slow down their breathing. It's not something I would say that it would be all too common. One thing I would be careful of is, and I just now thought about that, is tetany. So whenever a patient becomes alkalotic, what happens is albumin's a negatively charged protein. And so it likes to have protons binding onto it. If you get rid of a lot of these protons because you're becoming alkalotic, you have lots of negative charges that are exposed. Calcium will bind on to all that albumin, and calcium levels in the blood will start to deplete. And if you have hypocalcemia, you can actually start developing tetany. So perioral paresthesias, the what is this called when you tap on the cheek, the Chopstick sign, and the Trousseau sign when you pump up the blood pressure cuff and they start developing the carpal spasms. So those are things I would watch out for as well.
All right, so we have a pretty good idea then. All we have left is treatment. What do we have to do to make sure that we take care of this patient and get her back to really her baseline?
So that's why when I was saying before is when you look at the patient, if they look volume depleted, oftentimes the answer is just to give them like normal saline.
Okay.
So I would give them normal saline, preferably for this patient. She's having like vomiting. She's not feeling too well. She can't eat or drink appropriately. So first thing, I would discontinue the diuretics. She doesn't have hypertension. She doesn't need to be on them. So I would discontinue that. Second thing is I would give her maybe like a liter of like normal saline. Keep an eye on that. See if it improves her blood pressure, if it improves her tachycardia, see if she's making good urine. Maybe check a BMP, see if the chloride's starting to kind of come up and the bicarb starting to come down. And you can even do a repeat ABG as well if you need to. But oftentimes, it's just going to be giving them fluids. There is one time where I would be super, super careful of giving fluids. So let's say that you have a patient. This is the only exception. Let's say that I have a patient who has CHF, right? Or cirrhosis, and they have lots of edema. In that patient, if you give them fluids, you're going to worsen their edema. And so I would have to be very, very careful with that. That's the only time, whereas if I have a patient who has CHF or cirrhosis and I'm continuing to diurese them, so I'm giving them like loop diuretics to get rid of some of their edema, what happens is with loop diuretics is it gets rid of a lot of your protons. And so it makes you alkalotic, but it helps to get rid of excessive volume. In this situation, I would add on acetazolamide to the patient's diuretic regimen if they're hypervolemic and they need to get rid of that fluid. So I put them on, like, for example, furosemide 40 milligrams. And then I would also add on acetazolamide, maybe 500 milligrams, give that to them. And what it would do is it help them to pee out a lot of that basic bicarbonate. So it'd bring the bicarb down, but also help them to get rid of the excess fluid. And so that's the one kind of scenario where acetazolamide may be helpful. Another little trick that I've learned is giving them potassium chloride. Why? Because what's the most common complication of metabolic alkalosis? Hypokalemia. If you give them potassium chloride, you replete the potassium. You give them chloride, it brings the bicarb down. So those are two options, but most of the time, hypovolemic cases, give them fluids back. Normal saline. And then if they're not hypovolemic, they're hyper, acetazolamide or potassium chloride would be the answer.
All right, case 4, respiratory acidosis. So only 2 left.
Oh, baby.
So for this patient, chief complaint, we have a 68-year-old male present to the ED with increased shortness of breath, coughing, and wheezing. The patient, a long-standing smoker with COPD, reports that his respiratory symptoms have progressively worsened over the past 3 days. He mentions increased wheezing, a productive cough, greenish sputum, and marked shortness of breath that has become significantly worse than the day prior.
Okay.
He uses supplemental O2 at home, but has been using it more frequently over the last few days. So past medical history, COPD diagnosed 10 years ago, hypertension, and a former smoker, 30-pack years. However, he did quit 5 years ago.
Good for him.
Medications, tiotropium, salmeterol, and lisinopril for his hypertension. Upon his review of systems, we find respiratory reports increased cough, that green sputum production, and wheezing. Cardio, no chest pain, reports palpitations though. And for his neuro, no headache, dizziness, but there is increased fatigue. Vitals, his blood pressure is 145/85, heart rate is 102, respiratory rate is 26, which is we're up there.
Yeah.
Temperature is 37.8, and his oxygen saturation is 88% on 2 liters of nasal cannula oxygen. For his physical exam, we have an elderly male in respiratory distress, audible wheezes and coarse crackles on auscultation, really noticing some use of accessory muscles upon him breathing. Cardio, tachycardic, normal rhythm, no murmurs, and for his abdominal exam, it's soft, non-tender, non-distended. For some pertinent lab testing, we have sodium is 142, potassium is 4.2, chloride is 100, bicarb is 32, BUN is 19, creatinine is 1. For our ABG, we have a pH of 7.3, PCO2 of 60,
Hello.
PO2 55 millimeters of mercury on 2 liters of oxygen nasal cannula. Okay. All right, Zach. So a lot of things going on, but I think in the history we've pretty much spelled it all out.
Yeah.
Big time COPD.
Yeah, exactly.
Previous smoker.
Yep. Yeah.
Accessory muscle use.
Yep.
What do you think you're seeing here, and how do you kind of approach this case?
I think you kind of said it. It's always for your respiratory problems. A lot of acid-based disorders, and really any disease itself, you require a good history and physical exam. But oftentimes for acid-based disorders, a history and physical will do you better than any other kind of test would. For this patient, I kind of look particularly, for example, I kind of make a diverging kind of thought process where, do they have like an altered mental status? Is there any underlying neurodeficits or weakness? If there is not, then I ask myself the question, are they having any kind of wheezing or coarse crackles or rhonchi, anything that suggests truly a limited airflow, so airway obstruction of sorts? This patient has wheezing. As Rob said, they're a persistent smoker. They've been diagnosed with COPD. They're having difficulty with their breathing. This tells me it's likely a limitation in airflow, especially expiratory. It's likely an airway obstruction. Another thing I like to look at is, do these patients improve with bronchodilators and steroids? Because if they do, for example, let's say that they have asthma, they have COPD, you give them a chunk of steroids, you give them some albuterol as well as some ipratropium bromides, which are short-acting ones that are going to dilate the bronchioles. If their wheezing improves, if their breathing improves, and their CO2 starts coming down, that could also suggest that this is a lot of airway obstruction in this patient. So that's the way I would look at it. This patient is super obvious. Now, let's say that they weren't obvious. There wasn't anything on their physical exam that suggested that there was airflow limitation. Instead, the patient was maybe less arousable. You're trying to stimulate them to wake up. Hey, Mr. Smith, open your eyes. Hey, Mr. Smith, look at me. Hey, can you talk to me? And they're not really talking to you, and they're really, really lethargic or obtunded. That's when I'm thinking, okay, something's suppressing their respiratory system. That's when I would look at kind of possibilities of drug overdoses. So especially if they're not taking any breath. So if they're apneic, I would start thinking, is this an opioid overdose? Maybe reverse them with naloxone. Is this a benzodiazepine overdose? Reverse them with flumazenil. If they, boom, wake up and all of a sudden they're breathing normally, you've kind of established a diagnosis of an opioid or benzodiazepine overdose. But if they're having, let's say, example, you're talking to them and they're less arousable, but on top of that, they're having focal deficits, weakness on one side of the body. Then I'm thinking, oh shoot, could they have some type of like stroke or bleed or something in the vicinity of the respiratory center that's suppressing that drive? That's when I would say, oh, they're not improving when I gave them naloxone. They're not improving when I gave them flumazenil. This is probably not a drug overdose. This could actually be something structural in the brain. So that's the way I would kind of like form these differentials in my head. This one, it's a grand slam with, as you already suspected, the COPD exacerbation.
With this patient, is there anything you're very concerned about? I know it's not as scary as like a metabolic concern, but is there anything that you're like, we have to make sure that we identify it and figure out what complications are they at risk for? Yeah,
I think one thing that I've noticed is that it can cause, for example, let's say that a patient has COPD. They've probably lived at like that this patient's probably lived at that CO2 of 60 for a while. So they've compensated. But in patients who their CO2 really, really starts to rise and it gets up there, it actually can suppress the brain and actually can cause kind of a decreasing level of arousal. We call it CO2 narcosis. And so it can cause encephalopathy. And so the patient can actually start to become sleepier and more difficult to arouse, which is kind of a scary thing. But one thing I think that's really important is with respiratory acidosis, it actually has been shown to actually kind of cause vasodilation of the blood vessels. And so if you kind of cause that vasodilation, it can increase blood flow to the brain. So if a patient, let's say, has a bleed or a stroke or some kind of like tumor inside of their brain and their ICP is already elevated, and they're acidotic, it'll dilate the blood vessels and push more blood into the brain. It'll increase their ICP even more. So those are one thing. I'd say having an intracranial disease and having respiratory acidosis is not a good thing for ICP issues. So that's one thing. The other thing I also like to look at for respiratory acidosis is their kidneys. So for metabolic problems, we either breathe faster or slower, depending if we're acidotic or alkalotic. So acidosis, you breathe faster. Alkalosis, you breathe slower. For a respiratory acidosis, what you'll actually do is your kidneys will say, okay, I need to do what? Okay, well, my pH right now is too low. I need to retain bicarb. And so what you'll notice is in patients who have chronic respiratory acidosis is their bicarb will be higher and higher and higher as a way to compensate for their respiratory acidosis. So that's something that I also like to look for in these patients. If I see a high bicarb and respiratory acidosis, it probably tells me that they've been dealing with this for a long time. But I'd say the big thing is ICP.
All right. So let's wrap it up here. We have to just figure out, how do we go about treating this patient with respiratory acidosis?
So I think we kind of lended to that topic and that discussion within the diagnostics, right? In the sense that if the patient has COPD or asthma exacerbation, their problem is bronchoconstriction. What do you have to do? Bronchodilate them. Best thing to do is to give them steroids. So methylprednisolone is a good one, especially if they're having a hard time breathing. You don't want them to be trying to take a pill like prednisone orally. So methylprednisolone's IV, give them a good slug of that. 60 to 125 milligrams is usually the go-to. We'll talk about that more in pulmonary though, but you'll hit them with something like that and you'll put them on Duanebs, which is albuterol and ipratropium bromide, and you'll do that pretty consistently. So you'll do it frequently to dilate the bronchioles. Now the thing is when you do this, right, it takes a time for these drugs to work. So there's something that we can hook these patients up to, like a little Darth Vader mask, and we can help them to breathe better while those medications are kicking in.
Boom, BiPAP.
Oh, baby, my man. Exactly. So BiPAP is kind of like the best thing. It's actually evidence-based for patients with COPD. Put them on BiPAP. You control their inspiratory positive airway pressure and their expiratory positive airway pressure. Basically, in layman's term, what you're doing is when you're pushing this air in, you're keeping their airways kind of stented open so that they can allow for air to leave their lungs. And so they're not hyperinflated, feeling like they have to work really hard to take a deep breath. So it improves their breathing and then gives time for those medications to start opening up the bronchioles, improving CO2 exhalation and release. So that's the big thing for this patient. There's nothing else that you really have to do. You don't have to give them like any bicarb or anything like that for this disease.
All right, then we only have one more left to go, and that would be case 5, respiratory alkalosis.
Okay.
So we have a 42-year-old male presents to the post-anesthesia care unit, the PACU, with complaints of severe pain, feeling extremely anxious following an elective hernia repair. HPI, the patient underwent an uncomplicated elective hernia repair under general anesthesia. Post-op, he started experiencing significant pain at the surgical site, which he rates as an 8 out of 10. He also feels very anxious, describing a feeling of breathlessness and inability to get enough air in, leading to rapid breathing. His past medical history, no real pertinent medical history, but he does have an anxiety disorder managed intermittently with medication. That medication he does take as needed is alprazolam. Review of systems, he reports for respiratory, reports rapid breathing and unable to feel like he can catch his breath. Cardio, no chest pain at all, does report palpitations. Neuro, anxiety, no confusion or focal deficits. So his vitals upon presentation to the PACU, blood pressure is 145/90, heart rate is 102, respiratory rate is 28, his temp is 36.7 degrees Celsius, and his oxygen saturation is 96% on room air. For his exam, general, patient appears restless and in acute distress. He's pretty anxious. Respiratory, rapid and shallow breathing, clear to auscultation bilaterally. Cardio, he is tachycardic with a regular rhythm, no murmurs present. When we inspect the surgical site, it's appropriate. There's no signs of hematoma or infection at all. The laboratory testing, the serum sodium is 140, potassium is 4.1, chloride is 104, bicarb is 22, BUN is 14, his creatinine is 0.9, and then upon getting an ABG, he has a pH of 7.49, PCO2 of 30, and a PO2 of 98. Again, that's on room air. All right, Zach, so we have an idea of the case. We know what's going on with this patient. What do you think you have to do to break this down and kind of approach this patient?
Yeah, so this is where, like, when you talk about acid-base disorders, a lot of the times the history will kind of give you more than even sometimes the ABG will. But nonetheless, we're looking at ABGs and trying to interpret them. The ABG is pretty obvious, right? In the sense that he has alkalosis via the pH. His CO2 is low, which means that he's likely having a respiratory driver of this. His bicarb's fine. So again, we can confirm that this is a respiratory alkalosis, a primary disorder. Here's the thing though. This is a kind of healthy dude. I don't really see any history of diseases, right? So for me, one of the biggest things that I like to think about as a reason why patients are breathing faster primarily is what's triggering the respiratory center to fire faster. Oftentimes, hypoxemia is the big trigger. And you kind of hit on this, that his oxygen saturation is 96, right? So he doesn't have any hypoxemia. So that's unlikely driving his underlying tachypnea. That would be something that would be concerning to me. Does he have pneumonia? Does he have maybe an exacerbation of an obstructive airway disease? Does he have pulmonary edema? Did he go, hiking Mount Everest and he had high altitude, kind of like a related respiratory alkalosis? But nothing pulmonary seems like that's the driving factor. And so if that's the case, I can divert all pulmonary pathology away. It's unlikely the cause. The other thing that I would think about is this patient in a lot of pain, or are they super anxious? And based upon their history, they don't really have any underlying diseases that would suggest anything except for anxiety.
Yeah, that's just the one that's staring you down.
And so they just had a surgery. So they got cut into. So they're probably having pain and they're anxious. So oftentimes in this scenario, if you've ever had kind of like a panic attack and you start breathing really, really fast, it's because that anxiety is driving your limbic system. It's making your actual respiratory center breathe at a faster rate. And that's why sometimes when patients get super, super anxious and they're breathing really, really fast, what's the one thing that you were always taught to do if you're kind of having a panic attack?
Breathe into a bag.
Yeah. And the reason why is when you're breathing really, really fast, you're blowing off your CO2. And sometimes patients will have a syncope event. And so you're breathing into the paper bag to retain some of that CO2 back into the bloodstream. So I think a lot of this is anxiety and pain ridden. And if you treat their anxiety and you treat the patient's pain, I think that their tachypnea will start to settle down.
So being that he has increased pain, anxiety induced, this is both stemming from heightened limbic system activity.
Exactly. And I think if we treat that, we'll kind of shut that down a little bit and we'll start to see that the respirations will decrease. If it was hypoxemia driven, I would say, I got to take a look and maybe get a chest x-ray, CT scan, figure out what's going on in the chest that's driving their hypoxemia and then fix that. But I don't see any of those things.
That would be the SpO2.
Yeah, exactly. If that was really low or, there was other concerning signs that they had significant work of breathing or whatever it may be, then I would be a little bit more concerned. But for this one, it doesn't seem like that. There's a super rare one out there. They always add this into the exams, aspirin toxicity or salicylate toxicity. Okay. It's one of those weird one of those weird types of situations where a patient can have a mixed disorder. They can have respiratory alkalosis and an anion gap metabolic acidosis. And so usually with this one, you're seeing a young child who has tinnitus, they're having headaches, and they have fast breathing and an elevated lactate level. I don't see any concerning signs here of aspirin toxicity. If I wanted to, I could check an aspirin level if I was really concerned, but I don't see that being the case at all. And so based upon history, physical exam, and then just looking at the patient, I think that this is likely anxiety, pain-induced. Give them that medication, so something to kind of make them a little bit less anxious, treat their pain, and then hopefully we can trend down and watch the respiratory rate go.
It is pretty neat to see the overall theme of all these acid-base disorders. It's like if you get a really good history, you have a really good exam, you're pretty much understanding exactly what's going on.
Yeah, labs
prior
are
to
great.
getting one lab.
Labs are great, but I think that they come with certain limitations.
Right.
And I think oftentimes being a clinician is really being able to pull information from your patient a lot of the time. Yeah.
That's pretty cool. All right, so we have an idea. We've gone through a lot of that pathophysiology and clinical findings. What about complications? Are you concerned with anything going on in this patient?
Yeah, like I said before, I think one of the big things is respiratory acidosis can increase ICP because it increases cerebral blood flow. With respiratory alkalosis, especially if it's kind of transient, it can cerebral vasoconstrict. So it can reduce blood flow to the brain and they could syncopize. So that's one thing I would watch out for. Oftentimes in the neurological ICU, we use this technique to reduce patients' ICP. So for example, if they have an ICP of like 35, sometimes what we'll do is we'll actually, if they're on the ventilator, we'll turn the rate up on their ventilator and we'll make them breathe faster to blow their CO2 off so it constricts the cerebral vessels, reduces blood flow, and reduces the ICP. But that's more of a therapeutic usage. The complications of inadvertent respiratory alkalosis oftentimes could be syncope. Otherwise, there's nothing really else that I would be super concerned about off the get-go.
Cool. Well, hey, let's keep it simple for the viewers, right?
Yeah, exactly.
You don't have to go too crazy here. Let's move into treatment. How do we treat this patient?
I think that was kind of like one of the big things where it was kind of treat the underlying cause, right? So for this patient, it's pain, anxiety. I'm going to give them some type of pain medication, maybe start off with Tylenol, maybe NSAIDs. If that's not working, you can always escalate upwards if you need to opioids. But obviously those should be ones of your last resort if necessary. And then anxiolysis. So putting them on something that they maybe take at home potentially could be helpful to provide some short-term anxiolysis. That would be the thing that I would do for this patient. If they had hypoxemia, I would give them oxygen because that oxygen will improve their SpO2 or improve their PaO2, and it'll shut down the respiratory center from breathing so fast. And then I'd have to treat their underlying disease. If it was aspirin toxicity, then usually for those patients, we have to give them something to actually treat that aspirin toxicity. Oftentimes, though, we usually have to dialyze them if it's really bad. But that's kind of the big treatment for this patient is just pain control, anxiolysis. If they had hypoxemia, oxygen. Otherwise, this patient's straightforward. We're going to treat the underlying cause, and they're going to get better.
Awesome. Cool. Well, there you have it. We have 5 cases done.
Yeah, we killed this, man. That was pretty awesome. I really, really like this one.
Yeah, this was a good one. I think a lot of really good cases. I think they were very, very helpful.
Yeah, I think so. That's my kind of idea for you guys is that whenever you're looking at any patient who has an acid-based disorder, again, it's great to look at the ABG to figure out the primary disorder. It's great to have a good overall understanding of their labs, et cetera. But a good history and physical will lend to you pretty much more than any kind of lab could. So really lean into that HPI, lean into their physical exam. And I think that will give you a lot of valuable information to nail this on your exams and to nail it on the wards when you're treating your patients.
We're going to keep trying to do podcasts like this. Again, we have complete and total intentions to keep making them as much as we can.
Yep.
Just bear with us at the beginning here as we kind of get things going. We're still trying to, get a little traction, but I promise things are ramping up.
Absolutely.
And we're having a lot of fun with these.
This is great. I love this. And I really hope that this stuff makes sense. And I hope that at the end of the day, whatever way that you learn, I hope that we here at Ninja Nerd are able to provide that for you. If you like to watch videos, we got it. If you like to look at notes and practice on illustrations, we got you. If you want to listen to case series and go along with us as we try to solve a case, we got you. And if you want podcasts, we got you. So come here, check out all the things that we have to offer because our ultimate goal is to help you out in your academic endeavors. So yeah, thanks so much, Rob. This was a fun one.
All right, let's give them the send-off.
All right, Ninja Nerds. Well, I love you guys. I thank you guys. And as always, until next time.